Good morning. Thank you for taking your time out so early. I know it's quite early this is, but I'm sure you just being here just shows how passionate you're about talking about the future of the NHS, I believe. So we will have people coming in and people haven't registered, so you can just show up, you can sit down and we will just have a discussion. I'll start off with the two panelists who have not been able to make it this morning. So we'll start off with a round of introductions and then obviously go straight into the discussion for today, which is the future of the NHS. My name is Fatima Kamara. I'm a management executive for NHS England. I'm also the Labour Link officer, and my background is I have been in the public sector, especially the NHS, for over 15 years. So I've worked within the sector from feet on the ground right through to management. So I think I have some sort of a rounded perspective, starting off as a nurse, working in the NHS, to bring to this discussion. So I am the host, and I've got my colleagues here, Sonia and Claire. So what we're going to do is I'm going to pass on to Sonia to introduce herself and also just say why this topic, the future of the NHS, is important to you and what that means for you. So, and Claire will do the same as well. Thank you.
Hi everyone, my name's Sonia. I'm a GP. I work in Tottenham in London, and I guess this conversation is important to all of us. Healthcare is important. I can tell you about a conversation that I had with a relative of a patient. So she had gone into hospital, found her 82-year-old mother in tears. Her mother needed the toilet, had been ringing the bell, no one came. So she found her 82-year-old mother lying in soiled bed sheets. And I mention that because I think, the public value the NHS because they know that the NHS is an asset, but we can't take that support as unconditional. And when you have elderly people not being cared for properly, when you have 7 million people on waiting lists, when you have over this winter hundreds of people dying every week due to delays in emergency care, when you have over half our maternity services rated as inadequate, it's not it's not surprising that patient satisfaction is at a 40-year low. We also, the principle. The principle of which the NHS was created, I think I'm happy to talk without a microphone if that's easier. The principle which the NHS was created, that wealth shouldn't determine your access to care, that principle is being eroded because increasingly we're seeing, and I'm seeing this even in my own clinic, and I don't work in a wealthy area, but increasingly I'm seeing people who can afford to are opting to go private. And I've seen even some really awful situations where I have, elderly people who are literally using up their savings to, let's say, get their hip operated because they've been waiting 1 year, 2 years for that operation, and they're living in their pain and they're becoming increasingly debilitated because they can't get access to care. So the NHS is in need of change, it's in drastic need of change. It's not simply about money, even though money is of course really important, nor is it simply about taking the NHS back to how it was. Patients' health and patients' expectations of healthcare has significantly changed, and it's significantly changed even from when Labour was last in government. So we need to meet that expectations. The NHS was created to deal with episodic illness. And actually, I think our expectations now is that we don't just have a sickness service, we have a health service. We need to have a health service that prioritises population health at an individual level and also at a national level as well. Also, I think people operate differently now. People want more, I'm seeing this particularly with my younger patients, they want more control over control over their health and also control over their care. And I think the paternalistic way that we deliver care doesn't work for a lot of people anymore, and that needs to change. Also, there is, and again, I guess it's a result of policies over the past few years, but there are cultural problems in the NHS that need to be addressed. Too often, and I've seen this myself, poor care has been normalised or tolerated, And also we have a culture, and I think it's because we've just been firefighting over the past few years, there's a culture that can be quite resistant to change, and that needs to change as well. So I think we need to be thinking about how we can transform our healthcare. How do we create a culture that is accountable, that is transparent, and also a culture that cultivates constant transformation and constant reform. We need to, we have to, I know innovation is the buzzword, we have to invest and we have to incentivize innovation. That will cost money. We need to be investing in the equipment, in the systems. I think if you talk about innovation in the NHS, a lot of my colleagues will just laugh at you, because literally we're working on computers that take about sometimes half an hour to load, and we have all these different systems. It's so backward, and I think if you don't work in NHS, sometimes you don't realise how backward the systems that we're working in. So it's going to need a lot of investment initially, but that if we invest now, then there's a lot of money to be saved in the long term if we increase efficiency and reduce the time wasted that we have in the NHS. We also need to be thinking about how, when innovation happens in the NHS, how that learning can be spread throughout the NHS. Sometimes we have like pockets of good things happening, but that's not getting spread throughout the healthcare service quickly. We need to be thinking about how we can spread that quickly through the NHS. We need to be thinking about how we can use innovation to empower patients, take control over their healthcare, and how we can use technology to do that. And also, of course, we have to have a motivated and supported workforce, we're able to harness the power of technology as well. And I think conversations can be, when we have conversations particularly in this setting, can be quite negative about the NHS, but there is massive potential in the NHS, and we need to unleash that potential. Data, for example, because we have a universal healthcare system, there is massive and rich amounts of data out there. Now, if we have the right legislative framework in place, which is important because who owns that data and how that data is used is really important. If we have the right legislation in place, then we can potentially use that data to really transform how we deliver care. And then also outside the NHS, if we look at life sciences, if we look at health tech, these are industries that are really growing in the NHS. So if we can invest in these industries, not only is it creating jobs, but we can become world leaders in these industries, and again, we can transform how we deliver healthcare. So to finish, yes, the NHS is in a really difficult situation. You all know this. We will be inheriting a difficult situation when Labour comes into government. But I think there's a real opportunity here. There's opportunity here to how we can transform healthcare and how we deliver healthcare in this country. And I think we really have to be ambitious here. We have to be bold. Health is an asset. The public understand that, so we need to, we need to be ambitious, and we need to deliver for this country. And I think we need to have a plan as we go into government, and we need to be ready for that. And I guess we sort of have a duty to this population. And I've been working at NHS for 10 years now, and I've seen over that time the care that we're giving to our patients and to people in our communities. That care is declining, and it isn't good enough. So we need to be ready to live an ambitious plan to transform how we deliver healthcare.
Thank you, Sonia. I just wanted to add to that if you have any questions, we'll do Q&A at the end. So if we just do the introductions and then do the speech, and then if you do have any questions at the end, you'll be given an opportunity to ask your questions and take things from there. So I'm going to introduce Claire. Claire, can you tell us a bit about yourself and what does the NHS mean to you, and why is this topic very important to you as well?
Okay, thank you. I'll stand up to make life a little bit easier. So I come from a few perspectives really to the NHS. First of all, I'm chair of an NHS Foundation Trust in Nottinghamshire. I've been on the board for 10 years, and I took over a chair in 2021 at Sherwood Forest Hospital Trust. I also am a director of Pharmacy Defence Association, and have worked within the pharmacy and consultant to pharmacy and pharmaceutical sector for the last 13 years. So I look at it from two different perspectives, one in terms of the acute sector, and secondly from the wider primary care sector. And then the third reason of interest is I am a candidate for the East Midlands Mayor, and whilst that responsibility does not include, at least on the box, the health and social care framework. Certainly not what we see that Andy Burnham has in Manchester. I do think there are some huge opportunities. So perhaps touching on all of those areas, but starting with the trust and where we are in the acute sector and what those challenges are. I mean, I can tell you that what I've seen in the last 10 years across the acute sector, every year we think this is the worst year that we will see it, and as we head towards winter, we repeat that mantra. You know, last year was the worst year that we saw. We will head into another year and it will become more and more difficult. And the reason why it becomes more and more difficult, certainly in this year, we have the added factors of the strikes. And the strikes have brought us massive problems in terms of the backlog for our patients. It's really challenged our workforce, those who either have taken strike action and those who have remained, and in order to be able to pull the organisation together and keep operational. And the third reason is because we know that no matter how hard we try, that there will be impact upon patients. Mm-hmm. There will be patients out there who, as a result of the delays that they're going to be facing, will have possibly a shortened life expectancy. They may well have long and ongoing health problems as a result of that may not be able to be cured or solved. Our other challenge is, of course, workforce. And now we know that everywhere is having a challenge, and it doesn't really matter whether or not it's health service, it's the retail sector, it's all sorts of jobs. It's a big difficulty, but for the health service, we need people within a pipeline who've been trained over several years. And that pipeline has been cut off by the Tories over the last 13 years. And the reality is that we are really seeing the impact of that now. And then, of course, there's the relationship between health and social care, where we have patients who are medically safe for discharge and we have nowhere for them to go. And the impact that has upon patients, but the impact, of course, upon the flow within the hospital, brings us massive challenges. So, and I'm sure that there will be plenty of people to engage in that discussion. But I see it, of course, also in the community sector and in primary care too, where many of the members of the Pharmacists Defence Association, and we are the largest membership organisation in pharmacy, have decided that community pharmacy is such a difficult environment in which to work. The pressures upon them, placed upon them to deliver services, to deliver consultancy services within a community pharmacy setting, but also to provide an increase in the number of prescriptions for people, means that many pharmacists are deciding they don't want to work in community pharmacy. The financial settlement for community pharmacy sector has been cut significantly over the last few years, and the tightening again of that landscape just means that many pharmacists are working within primary care, they're moving out into new roles that they see as being an opportunity to provide much greater clinical engagement with their patients rather than perhaps meeting the targets within a commercial sector of community pharmacy. So from that perspective, we are not utilising our primary care to the same extent, and I think to the ability and capacity that we need to, and joining up so that we get patients moving from accessing community care as the first point of call, utilising their pharmacists, utilising the different services that are available in order to support a better sense of health and well-being. So what's the future? I think the future for the next Labour government is not just to come in and say that money is the solution. Yes, of course, we do need more money, but we also need to use the funding that we currently have better. We need to make sure that we've got much better relationships with our staff and with our workforce. And we've got to make the NHS seen not just as an archaic institution that becomes, as they say, something that everybody believes in, everybody supports. But once you get into it and you start to work in it, you realise some of those flaws in the way in which we work, the way in which we engage, that interaction across the different sectors. So those things need to be changed. I think we need to look at the way in which we engage as an anchor institution. So one of the things, and I see Andy Abraham sitting here from Mansfield, the Mayor of Mansfield Council. One of the things that we've done as Sherwood Forest Hospital Trust is to really take, with great responsibility, our role as an anchor institution, one of the largest employers within the area, the ability to be able to influence not just what our patients do, but what our staff do, and therefore broader what our community does. And to do that in terms of the health and wellbeing agenda for all of those patients, looking at it from workforce perspective, so that we work with the local colleges and with the university to bring courses out of the city of Nottingham into our local community, so that we are able to recruit people who don't feel able, for a range of personal reasons or family responsibilities, to track into Nottingham on a daily basis to do their nursing associate course, for example, or indeed other opportunities. To look at the way in which we design courses with the local college that will meet our needs for the future as a local employer, and to work connected into local authorities to think about that health and wellbeing agenda, and to do that based on place. And I really want to emphasise that importance of place. So all of those aspects are something that I'm particularly interested in. And clearly, as I go forward and an election next year as Mayor in May, I'm interested in what we can do with that convening power of the Mayor, not just what it says on the tin in terms of the legal responsibilities and powers, the duties and powers of the new Mayor and Mayoral Authority, but to think how important health and wellbeing is to every aspect of people's lives. And how do we influence that by making sure that the NHS, not its sort of executive responsibilities, but deep into the psyche and to the responsibilities of primary care, how do we make those work for people? How do we connect them in to local authorities so that we are focusing the issues that matter, that are going to change people's lives, that are going to make them healthier, that are going to make them fit for work, that are going to ensure that in those longer term we don't have problems building up. But priorities are, we are going to have to clear that backlog. And so I'm going to be really interested to hear what West Streeting says on Wednesday, tomorrow, about what we do on those things. Thank you.
Thank you very much, Claire, for that, and also Sonia. I think what we would take out of what we've mentioned, the previous speakers have mentioned, is that the NHS celebrates 75 years today. Well, this year. What we also need to, I think, just looking back, is actually when you think of its age, 75. Do you know what I mean? It's gone through a lot of, even from a physical human perspective, someone was 75, they've gone through quite a lot of health issues, challenges, and kind of, getting on in life. And how do you support them through that process? And I think if we look at that from that perspective, and also how the NHS was initially, how it came about the Second World War. Obviously, mortality rates were different, health issues were different, people are living longer, and also when you think about the clinical perspective of it, we've got more drugs to keep people alive for a longer bit of time, but also comorbidities as well. And so it feels like it's broadened, because things have moved on in leaps and heaps from when it was set up. And that is why, if you look at the NHS in itself, that it's gone through from SHA, PCT, ICB, CCGs, all of the acronyms, do you know what I mean? And I think also what that means is, aspect, having worked in the service for quite a fair amount of time, is you can see that there's a bit of wastage. There needs to be a whole system redesign with regards to the services and how it's offered, and also patients having access to services, and the GPs being the point of entry to services. But Claire mentioned about also staff and retention, and so did Sonia. We have an aging workforce, but also trying to get people to want to work in the NHS, because they hear about all of these things. They don't really want to work in the NHS, because actually, as much as I always say to people who work for the NHS or within any health or social care, and stay on for a length of time, they're really passionate about what they're doing. They're not doing it because they want to be paid huge amounts of money, because if they do, they'll be finding alternative employment anyway. People spend their time as nurses, doctors, OT, HCAs, training and wanting to give back, but the support sometimes is not there, and the structures needs to be looked at more carefully. And I think the other point that we should really think about really loud and care is about social care, because we cannot fix health without fixing social care. The two go hand in hand, which is why we have issues with regards to someone wants to be discharged home. They cannot, there's nowhere, as Claire said, to put them. There's no domiciliary services, and they can't take them on board so quickly, and they're bed blocking. And even though they're perfectly okay, maybe with some supportive care to go home, they're bed blocking at maybe £500-600 per bed per day, and that is money that's going down the drain. And then maybe they moved on to somewhere else to give them a bit of respite, and that's an additional cost where they can be looked after at home. So, and what I would summarize is that the NHS has been through a lot. I think if you haven't looked at, there's a report that West Streeton did with the Fabian Society, the National Care Service, which talks about, and it outlines sort of the overview in terms of the Labour Party, what he's hoping to achieve with the NHS and what that looks like. So if you haven't read it, it came out I think June this year, and a lot of work had gone into it, and working with various sectors within the NHS and public sector, and how that would spell out in terms of the Labour Party. And I think the NHS is one of the flagship achievement for the Labour Party. We helped set it up, and you can't start off with something and just leave it to go its own way. And I think that's really very clear in terms of what the Labour Party is saying, that we've seen so many things go wrong within the NHS. We are you can't, if you need staff need to be trained all that length of time, and also the strikes. I haven't, in my years of working in the NHS, the past couple of years, I've never experienced so much apathy, tiredness, just people who are just really, really burnt down and thinking, what is this? Every strike going hits the NHS staff. So, I think it's what do we do about it, and how can we ensure it's a service that we need. It's not optional, even though health means different things to different people. At some point in life, every one of us is going to want to access the NHS. So it's in the interest for all of us to be able to come together and say, what do we need to do? And especially when the Labour Party come into government. So what do we need to do to make it stand back up, to make it a bit vibrant, to make it fit for purpose? I know this word people use it all the time, and it's just like a buzzword. What is fit for purpose? But something where if a GP, someone goes to a GP, they know they're going to have their appointment within this time. They're not left on a waiting list for X amount of time. And also you have IT machines and systems and software. They're not aligned. They're not talking to each other. And then you're supposed to send an appointment, and the patient doesn't get a letter. And a year and a half after, you realize, wow, so it was sitting in this sort of dead space nobody knew about. So I think it's a work in progress, but I think we shouldn't. It's not like we shouldn't give up on the NHS. It's our pride and joy of the United Kingdom. I would say it does need a lot of TLC, 75 years, but also we need to be quite proactive and actually look at a whole system redesign of the NHS, not with regards to money, because people will say, oh, we need some more money into the NHS. Well, actually, if you look at how it started 75 years ago, I'm sure to date that in terms of comparison of financial funding, it's very, very different. Do you know what I mean? But I think it's how we look at what do we do now for this stage of the NHS and for the people that actually need to access the NHS. So that is what I see. And I also think within social care, there needs to be some joined up working within health and social care. It feels, most of the time, it feels like social services is on the other side and health is on the other side. And actually, how do you marry both together? They need to be in a sort of combined relationship and be able to, when someone goes on the ward, start thinking about how they're going to discharge, start thinking about who's going to look after them. I think all of that has been done, but when you get to the point of actually implementing it, if you haven't got the staff, if you haven't got the service, if you haven't got, what can you do? So it makes it really, really difficult. I think this sort of conversations need to be heard, but it also just shows that I think the Labour Party, when I went to the launch of the National Care Service report that West Streeton did with Fabian Society, I felt a bit hopeful that a lot of thinking and work has gone into, it talked about joined up working with health and social care, what does that look like? And also people realizing that even though you think you might need more money, but what is more money? The purse strings are tight, everyone needs more, but you need to make whatever works and also maybe avoid a lot of duplication and things like that within the health service. So that's what I would say. And then I want to maybe ask Sonia. Sonia, what do you think at this point in time? So we've talked about the past in terms of how the NHS was set up. We've talked about the here now and the challenges that we face. What do you think are mainly, so obviously with the SME for Labour event, what do you think are the first, so if Labour was to come into government, what are the first 3 or 4 things that you think, I'm going to put you on the spot a bit, sorry, what do you think of in terms of a GP, what do you think that your, sort of bugbear that you would want sorted out in the first 100 days, for example?
In the first 100 days?
Yes.
It's a lot to sort out.
3 or 4.
3 or 4
yes.
things. So I think, as Claire mentioned, we have to get the waiting list down. I think it's sort of like, you can't have people living 1 to 2 years living with pain, their conditions getting worse because they're not getting access to their treatment. So that needs to be done immediately. I think the first 100 days is difficult, but I think there's a few different bugbears that I have in the NHS. One of them is the fact that our services are quite fragmented, and people don't sort of quite understand this if you don't work in the NHS. But for example, like a patient goes to hospital, I don't have access to those hospital records. Or let's say when I was working in the hospital and a patient got admitted to hospital, let's say a mental health patient got admitted, I wouldn't have access, and they were having sort of a mental health issue, I wouldn't have an access to their mental health records because the mental health records were on a separate system to the hospital records, which are on a separate system to the GP records. Which is really quite bad for patient care when you don't know what's happening. And actually a lot of, and I see this a lot in some places, I get patients go to hospital and they come to see me, things have happened, medicines have been changed, and it's because the hospital consultant didn't know what was going on with the patient, and then it's this constant, so you get mistakes being made, care not being done properly because of that. And so in my other hat, I am a GP, but I also used to work in national health policy. So it's interesting because integration was like the buzzword when I was working there, and everyone's talking about integrated services. But I think it's quite difficult to do because actually we're on different systems, which is a massive problem. So the GP system that we're on, we've got two different systems that are used nationally. So even certain GPs are on different systems, and then the hospitals are on different systems, and then also mental health care is on different systems. So I really think it's important that we have one system that we're all working on, so we can all see what's happening and working together on that. And then integration, again, is it is a buzzword, it's used a lot, and the whole point of integrated care systems was to try and integrate services. It needs to be done a lot better. So we need to be thinking about how we bring GP services, mental health services, but also other services in the community together. I guess I'm really interested in health inequality because I work in an area where, it's the health, and we've got 5 clinics where I work, and we've got a few clinics in what I'll call Will Tottenham, and then we've got another clinic down the road, which is much sort of a nicer area. And the difference in health between these patients is so noticeable. And I think we need to be thinking about how we can reduce health inequalities. And that doesn't just come through the NHS actually, that comes through other services. So how we can get people being more active, eating better, living more healthy lives is really important. And so reducing health inequalities is actually something that needs to be shared across government and not just in the NHS. Of course, social care, you mentioned it already, is a massive problem. We have to be thinking about how we can have a care service that's there for everyone, that's fair, that's universal, and that gives good care. And then I think primary care, there is a real issue with I think the way we do primary care just doesn't work for a lot of people anymore. And there's too much variation in primary care as well. And I think it needs a real rethink. But I think just how people get appointments, how people see their GP, and then also just really basic things of people, if I refer someone to the hospital, that patient needs to be able to see what's happened, where they're referred, when there's appointment, just a lot more and more transparency and openness with the service is really important. And then I know you said we don't need money. We do need money. It's not like we just. I guess money is important. And if you look at what's happened with funding over the past 10 years, funding has significantly reduced. And if you look at the declines in and I say this from someone that worked in national health policy, if you look at the declines in care that we've seen, it does correlate to the decline in funding that we've seen in the NHS. And actually the NHS is a very economically efficient healthcare system, and if you look at sort of other healthcare systems, if you look at there's countries that do deliver healthcare better and have better healthcare outcomes, like some certain European countries, but they are spending significantly more money. So money is important, but it's not just about money. There's other things that we need to do as well. There's lots more that needs to be done, but yeah.
Thank you for that, Sonia. Claire, do you want to answer the same for us, please?
Yeah, I think there's a few things that we need to look at, and I'll probably focus very much around the use of medicines. The second biggest spend in the NHS after workforce is medicines, and the 8% of all our hospital beds, the admissions are based on people who have either not taken their medicines properly, not taken them at all. But certainly, as a result of that, we see people in hospital in acute settings. So there's something there about the way in which we provide support and medical care, and a greater need for us to provide pharmaceutical care. And the experts in that are pharmacists. And too often, I don't think we as a society, or indeed in the NHS, really value what that profession is, and that is not somebody who's a mini doctor. Mm-hmm. They are somebody who's an expert in medicines, and they have very, very different skills and services. So the first thing I would be looking at is how do we reduce the number of people who are going into hospital as a result of adverse reactions because of medicine, either not taking them or taking them inappropriately. How do we make sure that we advance and support the use of pharmaceutical care, and therefore the reduction in the number of medicines that people actually take? And that can be done through greater use of pharmacists in community pharmacy, but also those pharmacists who are engaged wider in primary care, either based at GP surgeries or through their primary care networks. I think we need to recognise that those pharmacists therefore also need to be able to have access to read and write on patient records. Again, another challenge, as we've already heard from Sonia, for GPs, but also for other professions, when they're trying to find out what's going on with patients, they're not able to have joined up systems and to have that read and write access, and that's important to be able to do that, to provide the continuity of care. But I also think there are areas that we could move on quite quickly in terms of services. So we know, for example, that obesity in this country is a growing problem with comorbidities impacting so many of our patients. And I know, as Andy, and I know there's also one or two other colleagues here who are pharmacy professionals from the Nottinghamshire area. They will understand that we've got quite a significant issue around poverty and poor health and obesity across the North Nottinghamshire, and as a result of that, see much higher levels of dependence on services within the NHS, and we need to tackle that very early on as part of our health and wellbeing strategy. So, you think about children, those of you who've got primary children or have had primary children going through the primary system, when they get to year 6, they get an assessment by the local health services for weight, and the parents get sent a letter. The children get weighed at school, they get sent a letter which tells them whether or not they are under or overweight or sat on target. Where those children are overweight, the parents get sent the letter and effectively told, go and find some services and do something about it. That's never going to deliver the change that we need. And we actually need to join it up. We need to be thinking about first of all, what are we doing around free school meals? What are we doing about school food? Because that's the area of greatest levels of influence. How are we teaching those children and families about better food, better nutrition, better activities? Once they've had one of those letters, what do we do? Why are we not referring them in as a whole family to support them through their local community pharmacy? We know that GPs cannot cope with it. It's not really necessarily their expertise anyway, but there are other services in the community that could support health and well-being for those families rather than simply sending them the letter and then abandoning them. So those are opportunities which I think are again about linking into that health and well-being, and certainly something that I'd like to see the next Labour government considering and getting support for.
Yeah, can I just add to that? So, obesity rates have doubled in the past 15 years. We have a third of our children who are growing up overweight or obese. And that's not only just harming their health now, but it means that later down the line, they're more likely to have health conditions, more likely to have premature death. And I think the strategy that we've had around obesity has just evidently failed. And I think and I've seen this over the past years, the strategy we have of just, just telling people to eat better, making people feel ashamed for being overweight hasn't worked. So we do need to really think about differently how we address obesity in this country. And I think it does come outside of the NHS, to be honest. I think we need to be thinking about how we can make being healthy, eating healthier food, the cheaper, more easier choice. And if you look at, I guess I work in quite a deprived area, but if you for the poorest 10% of households, if they were to follow the NHS healthy eating guidelines, that would be using up 75% of their disposable income. So actually be eating healthily and eating good, nutritious food is just unaffordable for many families. And also our shelves and our supermarkets are flooded with low nutritious, high sugar, high salt, low fibre food. That's very addictive as well. And that's what our kids are getting addicted to. So we do need to, I think, I really think we need to be challenging the food industry here about bringing in regulation to push the food industry to make our food more nutritious and to make healthy food cheaper as well. And then just a thing to touch on about pharmacy and prescriptions. I have one policy that I think would like to be brought in quickly, getting rid of prescription charges. So for those who don't know, every time you get a prescription, it's £9.
Yeah,
so if you're £9.65. So if you're someone that's got multiple health conditions that are on lots of medications, and you're getting medications every month, that mounts up really, really quickly. And I have a lot of patients, and I come in, I'm looking at their blood sugars. Their blood sugars are going all up and down. Their diabetes is not controlled. Their asthma is not getting controlled properly. Like, what's going on? And then they're not. Even though we're prescribing them medicines every month, they're not picking up from the pharmacy because they can't afford to. So I think getting rid of prescription charges is really, really important for reducing health inequalities as well.
Thank you, ladies. Thank you very much. So I'll open the floor for questions, please. Over to you, Andy. Andy, right?
Yes.
Yes.
That's right.
All right. Thank you.
So you need to do a triage on the NHS in the sense that, you know, what can you do immediately? Because first of all, the NHS is our most valued, precious thing, and morale is, you know, at its lowest ebb. And it's almost like, okay, what can we do immediately that's going to lift morale and start to make some changes straight away? And you know, all that knowledge that's come from the three speakers this morning says you have the solutions. So, you know, the bed blocking, and the thing that needs to happen is the governance via government needs to come together. It's all isolated. Department of Health, Department of Education, housing, and whatever. All the well-being involves all those things. So you know straight away that immediately, if you could get the homes ready, you'd start to get moved to the thing. Talked about the pharmacy. You talked about communication. So it's saying, right, okay, waiting for this fantastic computer system that's going to cost billions probably and never work. Well, there's got to be another way of doing it, you know, just using your phone and allowing the notes to transfer across. So, you know, they're not like sort of earth-shattering solutions, but there's blockers that stops like simple solutions being implemented. So when hopefully we get a change of government, you want to have this list ready that goes like, well, if you do this immediately, that immediately, this, you know, this in the triage, this is what we're going to do, and give it the boost, and then follow it up with, so prevention, localism, you know, that's the big thing, isn't it? And diagnostics, and putting the services in a straight line where the communities are, so it gets done locally, and they never have to get to hospital. So, you know, we've got a mental health partnership, and, you know, involves leisure and GPs and about transport and everything. It all needs joining up, and I think it is possible, but it just needs that kind of, the structures of government need to, they've got to come together. It's too much in silos, and that's what's stopping progress.
Totally right, Andy. Thank you for that. So, what's your name and where you're coming from? Introduce yourself, please. Thank you.
I used to work for the NHS. I joined in 2012 just as the Health and Social Care Act came in. And I never worked in the NHS before. The reason I'm saying this is that there's a background sometimes within laws and things that change that do impact directly on patients. The loss of institutional knowledge, the restructuring of the organisation, it would take years and years to bed in. And I worked in the data protection side of the information governance officer. And I think a lot of the public don't fully understand that change in law and actually the impact on data protections and the business of sharing data is actually massively impacted by that. Data sharing agreements were long and lengthy, bureaucratic, but they could be done. But laws exist to protect people's data, so an understanding of that's important. I also worked on the Care Data Pathfinder programme that came out in 2015, which was just horrendous. I've suddenly stopped because of the public didn't fully understand what it meant. There were lots of rules about data sharing data, but the data hasn't been protected for good reason. So that's a background. But one of the great things I noticed is I was talking to John Battle, which was the NP in Leeds before Rachel Reeves, and I thought one of the great innovations that came through at NHS was social prescribing, which massively impacts the health and well-being, and it's imaginative prescribing instead of drugs. He helped a prisoner came out of Army prison. A lot of them were going into these flats close by, letting themselves, suicide rates were high. And he just said, well, look, why don't you go out and have a coffee and talk? And it became part of the social prescribing instead of giving them drugs. And so I think, start on something, build on what we've got and reach out. no data protections, but let us be imaginative and consult communicate with patients. It is one of those top things in helping them understand the take that come with us, rather than being told this has been done to you.
Thank you so much for that.
Hello, my name is Catherine Pope and I'm a counsellor in Gedling, but before that I worked for nearly 40 years in the NHS as a physiotherapist and also a manager of community services, and I suppose I want to make a case for that gap between health and social care being about rehabilitation, and I think that's one of the areas that's been completely squeezed out as a false cost saving, when actually if we invest in enabling people to get back to the state of independence they had before they went into hospital, we'd actually save a lot more money further down the line. I'm thinking about health funding much more part of the whole economy, so getting people back to work, stopping people needing so much expensive care if we put the time and effort in, meaning that they can actually get up and make their own cup of tea, get themselves washed and dressed, go out to the shops, rather than ending up first housebound, then bedbound, and then in a care home, when with a bit more time and effort they could have been back to where they were before they needed intervention, saved them falling over, needing more money spending.
That's true. Very true. Thank you for that. Chris, you're going to come after. Can I ask you to go? Sorry, what's your name and where you from?
I'm Bren. I'm from Central CLP delegate. I used to work in the National Health Service in the 90s, and it was the point you made about the fact that when you're firefighting and you're working hard, you develop poor practices, but you become very affixed to them because they work, and therefore there will be resistance to change when you try and bring in new ideas. And the thing that I think you really need to have to do is bring people along with you. So you've really got to explain it, because they will resist it, and not because they're bad people, and not because they want to be bad or whatever. It works in their environment, and what we've seen in National Health Service is restructuring after restructuring, and people are disheartened by that. So that was the one point. And the second point I just wanted very quickly was to say, when you bed block and somebody's caught in a bed, for the actual patient themselves, they deteriorate.
Yes.
That's the additional thing, is that my mother-in-law went into hospital, and for various reasons she was there for far too long. She fainted while she was in there, and her health in all areas just went down by the time she was discharged.
Thank you so much for that. Chris?
Yeah, touch on the point that Claire made around workforce. So a couple of points. First is how have we seen the immigration policies impacting the talent flow into the NHS? And second is, in terms of getting people into the NHS and working for them, what do the panelists think about the role of tuition fee? And that is because the medicine course takes 5 years and is 9 grand each, so it's at least 45 grand. So this means that there's potentially accessibility issues for working class students who want to enter into the medicine field. So what do the panelists think can be done to ensure that we are inclusive and get not only the middle class students but also working class students into the profession as well? Thank you.
I think what I would say about that, Chris, is, like you mentioned, it's how do we get the broad torch, the broad stick, and get more people working within the NHS. I think before that, what I would also want to add is, we must not forget the B and C's. I call it Brexit and COVID. So the effect of that on the NHS and the public sector, where a lot of staff, a lot of backlog, things have happened that we still having the ripple effect of significantly within the public sector and the NHS. In terms of inclusion and diversity, I think that's definitely on top of the agenda. That's something that, the NHS, I know that the NHS employs at least, maybe if it's not 50 or 60% of black and ethnic minority work within the public sector and the NHS. But how do we sustain that with someone who wanted to go and do nursing, we used to have bursary. Now bursaries went for a bit I'm not sure if they're back. And so, you're not, you can't get a student loan any other way, but you have to have a bursary. So if you can't get some sort of upkeep, how are you going to be enticed or encouraged to even apply to do nursing? That's one of the things. And I think we really need to look at, when we talk about diversity and inclusion, we also need to think about representation, because it's very different. The buzzword diversity and inclusion, everything is diversity and inclusion, but how is that manifested? What does that mean on the ground in terms of what we're hoping to achieve? Is a key thing that needs to be looked at. I think there should be some sort of incentive or program, or getting people from lower class background, so to speak, or working class background, to see being a nurse, to see being an OT, a pharmacist, as a job and something they could have the potential of applying to work in. And also, I think also the in terms of entry levels as well, what does that look like? Maybe there should be an apprenticeship, I don't know, where people who have the desire and would want to do it but don't meet the grades, maybe it's another different way of getting into the sector. So that's what I would say. Sonia, what do you think? And then Claire.
I think, as you said, the NHS since its inception, has been reliant on overseas workers. You've got doctors, nurses and other healthcare professionals from around the world who've been coming over to work in the NHS. To me, that's a real asset. Actually, I love working in the NHS because it's such a diverse place to work. But I guess it has been a problem that we're not training enough people within this country. So I think we should do both. I think we should be making sure that we train people in this country, but also I think it's nice to have an open country where we attract talent from around the world and they come and work in our NHS, and I think that makes the NHS richer as a result. About your question about tuition fees and about working class people not being able to do medicine, I think that's a problem actually with most degrees now. So I think it's a problem. Tuition. It's not just with medicine that we have that problem. So an ideal world would make education cheaper, more accessible to everyone. Particular things, so if you want to particular things you can do, you do have access schemes in medical school. So I trained in Nottingham, and I can tell you now the best paediatrician now working in Nottingham got in through an access scheme because it's a good friend of mine. So he was from Nottingham, from an inner city Nottingham. So the access scheme, what it does, it gives you an extra year before you go into medical school, and it's from people from certain backgrounds. And they do the extra year. If they pass that year, then they get a place at medical school. And I can tell you that he is the best paediatrician in Nottinghamshire, and he got in through an access scheme. So I think widening those access schemes across medical schools would be really important. But ideally, I would like to see tuition fees come down and for medicine to be more accessible to everyone.
Thank you so much, Sonia. Claire?
I think we know that workforce is a challenge, and the reason why it's also a challenge is not just because the whole of the economy is finding it difficult to fill some of the vacancies, but we also need to make it attractive again for people to want to work in the NHS, and we do bring people in, but equally they know it's a very difficult environment, that they have increased levels of stress precisely because we don't have the supportive workforce and enough people in there to do the roles. I think sometimes we have to sell it a bit better. I mean, they are. Everybody talks, politicians do, in shorthand about doctors and nurses as if they're the only people who work in the NHS. And I think we need to sometimes change that language. There are over 300 different career possibilities within the NHS. And we need to start by taking those opportunities out into local communities, working in partnership with local colleges and universities to showcase what those roles are. So that there are opportunities for people to come in, not necessarily having gone to university, but to be able to work their way through and to learn on the job, and then to do perhaps access courses or to do studying through day release type opportunities. And I think that's something that flexible working and flexible learning is really an important part of where we need to change. It will also help us not just to look at school leavers as the next generation, but to be thinking in different roles how we might recruit some people back into the workforce, or indeed to change their current careers into doing something else. I think the way in which we adapt about the medical training as well, to make that a bit more flexible. So, you know, I can talk specifically about the pharmacy area. In the next 3 years, every pharmacist who comes out of pharmacy school will be trained to have the independent prescriber qualification, which gives them a whole new expertise that they are able to supplement in terms of their work and to prescribe, particularly on common conditions. And a new common condition service being rolled out across community pharmacy will once again help us to make sure that people are directed to the right place for treatment and for diagnosis and prescription, rather than overwhelming local GPs. And that will allow GPs, therefore, to direct their expertise to some of the areas that at acute sector we are struggling with, and to manage some of those patients so that they are not repeat attenders to A&E or coming to A&E to get attention when actually they really should be dealt with in primary care. And it's those sort of understanding about different roles I think is important.
Thank you so much, both of you. Just one more question and then we're going to wrap things around. Any question? Nanda, go ahead.
Morning everyone. So my name's Nanda Brown, and I've worked in the NHS for the best part of about 7 or 8 years. And I'm also a local councillor as well. And you know, I agree with everything that the panel has mentioned here today, and a number of the points that have already been made in the room. And on the point of you know, workforce and retention, because obviously the NHS is nothing without the staff, the people that are there. I just wanted to understand a bit more about what the panel's thoughts were around perhaps looking at ways in which we can kind of legislate or better enforce our public sector equality duties in terms of you know, how we're engaging with our staff, but also how we're engaging with our communities, but also how we supporting the staff once they get into the NHS to ensure that there are the career progression opportunities and the staff feel valued, seen and heard and supported, because happier staff leads better patient care. And then also, just what your thoughts are on that.
Okay, I'm going to ask Claire and just for 1 minute to reply to you, because we've got the next, so only Claire will reply and then we'll make it to a close if that's okay. You can have a chat with any of us after after this, but Claire, do you want to answer Nanda for me, please?
I mean, I just think we do need to be focusing on that workforce and how we understand all those different issues that you're raising, to make sure that we are able to bring more people into the sector to utilise those different skills that already exist. I'm happy to talk to you afterwards as well.
Thank you. Thank you very much. Thank you, Sonia. Thank you, Claire, for being such fantastic panelists. And thank you so much for coming this morning. I know it's early, but enjoy conference and we'll see you around. Thank you.